Ladies and gentlemen, distinguished guests, and esteemed colleagues, I'm Dr. Nigar, your host for this event, and it's my great pleasure to welcome you to the second OncoConnect Global Symposium. Today, we have the privilege of hosting a remarkable guest, Dr. Huren Sivaraj, who will delve into the topic of no-cost, next-generation capability building and oncology data management for clinical trials, registries, and real-world evidence. Dr. Sivaraj is the CEO and co-founder of OncoShot, a distinguished medical oncologist and a visiting consultant specializing in breast cancer patients at the National Cancer Center in Singapore. His commitment to advancing oncology data management for clinical trials, registries, and real-world evidence is truly commendable. Welcome, Dr. Sivaraj. The stage is yours.
So thank you all. It's a pleasure to be able to speak at the Global OncoConnect Symposium. My name is Huren Sivaraj, and I'm the CEO and co-founder of OncoShot. This topic today will be centered around transforming clinical research capabilities with the OncoShot platform. Before I start, I think it's important for us to appreciate that those of us who work in the field of oncology are probably working in one of the most data-driven specialties in medicine today. However, working in this very data-driven specialty, we also realize that we have challenges in our day-to-day practice, in our approach towards our patients, but also have challenges as researchers and as institutions or cancer centers with how we manage data at research and organizational level. And some of these challenges with data management and data sharing, centered around, for example, patients and oncologists, is because we are unable to access our clinical and also importantly genomic and biomarker data, given that most of this data is not yet digitized and consolidated in a single place. We are unable at the level of a patient consult to be able to ascertain how a patient in front of us has the appropriate clinical features that would warrant standard of care diagnostics and treatment. And we certainly do not have the ability to look at the patient's clinical profiles and immediately match them to relevant clinical trials that may be available not just in our center of practice, but also in the wider ecosystem. Now, if you take those challenges from a patient and oncologist level to the next level, which is at the investigator or researchers level, we find that there are a broader host of challenges centered around our ability to generate evidence from real-time digitized information. We can't actually go back on the data that has been collected to rapidly identify patients who might be suitable for clinical trial screening and enrollment. Importantly, when it comes to data sharing with collaborators, whether they be academic or industry collaborators, we have a lot of issues with moving patient-level data with speed and accuracy. And at the last stage, or at the last highest hierarchy of challenges, we then deal with assessing outcomes and assessing access at a population level. And this becomes a problem for hospitals and governments in terms of data by itself. And so we see that the core issue of data management and data sharing has various challenges at both the patient and oncologist level, investigator level, and the government level. And so we really need to think about the infrastructure that needs to be in place for us to solve all of these problems. However, resource requirements for data digitization, management, and data sharing is actually not very tenable for most of the world. And here we quote some data that is coming out from the developing countries, particularly in Nepal, where they have showed that the cost of setting up EMRs, and these are EMRs that have been customized to be implemented in developing countries, can still be a fairly large investment amounting to anywhere between 200,000 to 400,000 for small practices or hospitals. And in this case, the cost for much larger cancer practices or cancer centers could be untenable just for the purposes that we described. So when it comes to just data digitization of EMRs, if this is the cost that we are talking about, I think most healthcare systems today are not yet thinking about how do we analyze and data share. And this is where there becomes a need for us to consider what solutions we have available to facilitate data analytics, data sharing. However, I think most of the world is starting to think about these areas as the next generation in terms of data requirements. And I'd like to just allude to a report that came out in PwC about the leap forward. And in the leap forward, it is best described as how emerging markets over the next decades will be shaping their infrastructure from paper-based health solutions to digital health models. Although this particular paper doesn't talk about the definition of the new digital health models, I think we are now reaching a paradigm in terms of consideration of the various tools and infrastructure that goes around this new digital health model. And today my talk will be largely focused on data management and data sharing infrastructure that can solve problems not just as individual hospitals, but also as an ecosystem at large. So I'd like to introduce the platform of OncoShort. And the two things that we talk about here is in terms of capabilities, first being the technology for ecosystem building and management, and the second, from a use case perspective, facilitating data exchange to enable clinical trials. And probably the two key components in building up an ecosystem for data sharing is firstly what we call as the federated data sharing model, where essentially patient level data does not need to leave or move outside of the healthcare system. But at the same time, it can be governed and controlled rapidly for information sharing. And another important component being the ability to push such solutions rapidly. A typical time period for EMR implementation tends to happen over many months to at least a year, whereas such a solution needs to be able to be deployed within 1 to 3 weeks. And this is something that is possible with a plug and play capability. But one of the most important things is how do we actually facilitate the deployment of such technologies with the right incentives so that healthcare systems can continuously reinvest into their infrastructure and make better sense out of the data that we have. And these are the three fundamental components that actually go into the technology bit. And I won't cover the details of the clinical trials enablement, but it's suffice to say that when you have data that is well managed and that's constantly refreshed or updated, you can actually accelerate the process of identifying the appropriate trials for patients and also generating evidence from those patients. Today, the OncoShort platform has been deployed successfully across 5 countries, including Australia, India, Singapore, Taiwan, and Japan. And it works with at least about 15 healthcare systems, with a whole suite of hospitals that are looking to be onboarded over the next 3 quarters. On the platform today, more than 80,000 patients with cancer can be assessed in real time to bring the right and most appropriate clinical trial opportunities to the hospitals that manage these patients. And by the nature of the infrastructure that is provided, there are also 2 upcoming national level initiatives that will help to scale the implementation of this infrastructure across some countries. The platform is actively being used by some of the top pharma and CRO customers across the Asia Pacific region to bring clinical trials to data-driven healthcare system partners. Now, going into the detail of how data is collected within such an infrastructure, I think one of the key concepts that we like to bring here is the concept of a living registry data collection model. Now, what does it actually mean? In the living registry model, there is a focus on ensuring that we can collect a core or minimum amount of data that is essential for the broad range of insights that need to be generated about our cancer patient populations. And this data fields, as I will share later, constitute about 15 core information in 3 categories of demographic, cancer-specific data, and non-cancer specific data. But the focus here is to ensure the healthcare systems can continuously refresh on these 15 data fields over time. Now, when patients enter various studies or have data that is generated from sequencing or diagnostics, what we want to be able to do is enrich cross-sectional single point information upon this continuously updated longitudinal data set. And this is an important model of information or data management, where instead of hospitals and investigators participating in research that is transactional and where the data is then lost or kept in a data silo, it is actually consolidated within a single platform for which that data can benefit many other researchers who need to manage similar patient populations. Now, what OncoShot does is by ensuring a governance framework where an application that is deployed and managed within a hospital's infrastructure sits in a separate database here, identified in green. Now, this so-called database would manage approximately 15 data fields that I referred to earlier, where the data comes originally from source information like EMRs. And in many cases, this arrow represents a process of digitization, where OncoShot as a platform or a solution can actually deploy digitization tools for clinical notes and genomic reports. And that digitized and structured information is then de-identified and kept within the hospital's cloud environment. And separately, we have industry users who are looking to strategize clinical trials planning, who can make queries about patient cohorts. Let's say they're looking for a stage 4 breast cancer population with a PIK3CA mutation. They can shape such a query, and we can then compute on each hospital's data set to identify the number of patients who may be suitable. And in this model, industry partners can actually decide on which countries and sites to actually conduct their clinical trials. Here is a quick view of some of the information that is collected within this green OncoShot hospital application, where we take de-identified IDs, information about stage, cancer diagnosis, cancer treatment history, mutations and biomarker data, which typically comes on third-party hard copy documents. We digitize them and we actually capture the gene and alteration level data all on the platform itself. Now, essentially what this allows us to do at a national level and even at a hospital level is to be able to increase the quantity and quality of clinical trial opportunities, given that OncoShot actually works with some of the leading pharma and CROs across the world. We want to use this data to inform them about patient cohorts and strategize country and site selection. Then the system actually will facilitate an operational workflow where we can reduce the friction between sponsors and sites for site activation and feasibilities. When the study is then started, the healthcare system partners or the investigators can go back to their de-identified patient records, re-identify those patients, and then screen and enroll them into clinical trials. And last but not least, the same data set that is actively being managed can be used as the foundational infrastructure for real-world data. I think what's really exciting for us is the ability to build on that same infrastructure that is also provided at no cost to the healthcare systems to create other opportunities for registry building and real-world data collection. And I think one key point here that I want to add is that the sustainability portion of this comes from every interaction that comes between the sponsors or the industry consumers, where when it comes to hospital level data, it is an approval process that is granted by these hospitals. And in return, these hospitals would actually get a service fee to facilitate the access to record. And given the number of transactions that we're able to bring in via this platform, it then becomes a self-sustaining model for them to build and keep their infrastructure. So just to give you an example of a registry building capability, you can see here that investigators maintain data custodianship and control over what is shared. On the platform itself, they can maintain multiple registries across multiple patient cohorts. And what happens is, where specifically required, they can actually have the ability to create what we call electronic data capture or EDC capabilities to collect additional data fields. And at the end of a real-world evidence exercise, they can export that data and pass it back to industry partners or their academic collaboration partners. And such capabilities are actually built in as a value proposition to the healthcare system partners as well. What this registry building capability also provides is industry partners can actually discover hospitals or healthcare systems that have proactively already been building patient registries. They will not necessarily see patient level data, but they can actually unlock and view insights on the overlap between the data that they require and the data that may already be available within these healthcare systems. And this can then facilitate a lot of interaction between the sponsors who are looking for registry partners and healthcare systems as well. So one of my last few slides will be to show that we are currently deployed across several of these markets, and we're looking to actually partner with more hospitals, not just in oncology, but outside of oncology, to build clinical trial projects, registry projects, and real-world evidence projects. That's all. Thank you very much.
Thank you so much, Dr. Huren, for your informative presentation and for sharing your time and expertise with us in our symposium today. Your insights are truly eye-opening, and I'm sure that our audience has enjoyed being part of this event today. Thank you so much.
Thank you, Dr. Nika.
Thank you so much. Now, we would like to present a few questions from our audience who are more eager to know about the topic.
Sure, please go ahead.
So the first question is, what are the challenges in implementing OncoShot in countries that may not have electronic medical records?
Thanks, Dr. Niga. I think that's a very valid and pertinent question. Now, OncoShot is committed to working with a spectrum of healthcare systems. And if you look at that spectrum, it constitutes healthcare partners that are almost completely digitized. They have functioning EMRs. And not just that, their EMRs are capable of data sharing and having interoperability all inbuilt within them. At the other end of the spectrums, we also work with healthcare systems that are largely still functioning with paper records. Now, we are able to bring all that entire spectrum of healthcare service partners or healthcare organizations onto the platform because of our approach. And that approach for the non-EMR hospitals is centered around doing two things, both digitization and building that federated data infrastructure at the same time. So when it comes to digitization, we have the ability to deploy tools like what we call OCR, where we can read documents on paper and bring it and make it digitized, and then to recognize the digitized text and structure that information as the next step. And so what happens almost as a part of that seamless process is paper record becomes structured information. It's not just a digitized PDF document. It actually becomes structured data fields on the OncoShot database. So this is actually the concept of the right? Instead of just digitizing to have your PDF records on a system, you're actually also structuring that data on the database. And this is how we actually work with hospitals who don't have EMRs. I think eventually we want to be able to also understand if these hospitals have an EMR strategy, because I don't think you can run away from not having an EMR in the long run. But what is actually also very interesting is many hospitals use our platform as the first place to analyze their data or to view their data across the entire population. So this is actually a very interesting value proposition that we can bring to, as of now, non-EMR hospitals.
Thank you so much, Dr. Huren, for giving us a clear explanation on this question. Now, moving on to our next question. What about the costs and time for implementing these solutions for healthcare systems?
Yeah. So I think one of the best ways that I would describe the platform today is that in order to facilitate the speed and the ability to share information, we've really had to work with a introduction of a very, very different kind of a business model. And compared to the traditional business model of how hospitals actually bring EMR adoption, where the cost is actually borne by the hospitals, the business model of OncoShot is centered around almost free or low or no cost deployment for the healthcare systems. And we are able to do that primarily because there is a need and incentive that comes from the various use cases that I described, which is clinical trials, real-world evidence data collection, and registry building. But the ability to bring that data also introduces incentives, and we can actually then, in fact, revenue share with healthcare systems. So this revenue share is intended to firstly make it neutral or cost neutral for hospitals. So instead of spending money, they actually whatever they might even spend because of manpower and resources to just get it set up, they would cover the cost of that. But potentially, if there's a good amount of data that is continuously being enriched, it can actually be a very, very sustainable exercise in the long run. And I think this business model is actually key to allowing a lot of hospitals to also digitize and data share in a much faster speed than they would typically be able to do themselves. If they were to wait for all the resources to be gathered and then to build EMR and then data sharing capabilities. So this is how OncoConnect actually functions, and we believe that this is an important way by which we can democratize digitization and also data sharing for hospitals.
Dr. Huren, a big thank you for your answers and for sharing your expert insights with us today. Your contributions have been greatly appreciated in our symposium. Thank you so much.
Thank you so much for the opportunity to present our work. It's a pleasure.
Thank you. And also to our wonderful audience, we genuinely appreciate your valuable time with us at this symposium. This Global OncoConnect Symposium was brought to you by Medsynapse, a global medical platform that fosters collaboration and knowledge exchange among healthcare professionals. We encourage you all to join this fantastic community and be one among us. Once again, thank you all for your engagement and for being part of this meaningful event. Thank you, and until next time, goodbye.